We're going to start in next 30 minutes, 30 seconds. All right, so good afternoon, ladies and gentlemen. Welcome to International DOS Conference 2021. You are in Hall B, and that's the second session, which is Retina. So, before I start this session, I'd like to introduce the chairperson for this session, Dr. B. Ghosh, Dr. Lalit Verma, Dr. Dinesh Talwar, Dr. Sarita Berry, Dr. Rahul Mayer, Dr. Vinod Agrawal, Dr. Rohan Chawla, Dr. Sandhya Makhija, Dr. Manisha Agrawal, Dr. Vaibhav Sethi. Is there any chairperson available right now? I guess not. So we'll start with the first speaker, ladies and gentlemen. We are live now. So the first speaker for today is Dr. Muhammad Al Amri. Over to you, doctor.
Okay, you can see my presentation.
Yes, I can see.
Okay, thank you very much. Good morning to everyone here. Good morning to all participants. I'd like to thank those for this kind invitation. My talk is going to be about AMD and the new molecules for introducing to the market for management. I don't have any financial interest. So this is the agenda, my agenda. I think you know all, but this is just a reminder and certain point about AMD is a degenerative retinal disease that can cause central vision loss and lead to legal blindness. It is the leading cause of permanent visual impairment, blindness among the elderly, especially in the Western world. I think more than 50 developed countries, they are suffering of this. Age-related macular degeneration remains a significant public health problem. Sorry. AMD account for about 8.7% of all blindness worldwide, increasing prevalence as a consequence of exponential aging population. Global burden estimated to increase from 200 millions to 300 millions by 2014. I think we know this one, all of retina people, they know the evolution of therapy. Just I will go very fast about this one on that. We are having in the early laser photocoagulation in the early 80s, then it was followed by photodynamic therapy, then we have submacular surgery, and that's all they are only doing a whole process, just processing or progression of the disease itself. But there was no hope to improve the vision. While in the early 2006, early of this century, we are having the introduced to the market the anti-VEGF therapy, and because of that, we are having some hope to improve the vision. So factor influencing the optimal visual outcome in a patient with a neovascular AMD, very important. Treat early, treat sufficiently, and sustain treatment is very important. So just a very also small introduction about the molecule that I'm going to talk and to use and give my experience about this one is the brolucizumab, is the most clinically advanced single chain antibody fragment that designed specifically for ophthalmic use. This is the most important here, just to have a comparison between a four available anti-VEGF. We know there are three of them, they are approved to be used. The other one, just we are using without approval to be used for a treatment. We are having here the last molecule, the brolucizumab. The most important is the brolucizumab is very molecular weight is the smallest one. Clinical dose is 6 milligram. And the most important point here, relatively number of molecules per injection, it is higher than 11 times than the other molecules available. So it is more drug in a single injection, potent inhibition of vascular endothelial growth factor A, effective penetration of retina and choroid, rapid systemic clearance. So now we'll move to my experience while using this medication. This is the first patient, 72-year-old male patient, not diabetic or hypertensive, known of with AMD bilaterally. This patient was followed with me from 2016, and I was using for him several different types of anti-VEGF from the Lucentis to Eylea, and we use about 14 injection in the right eye, 6 injection in the left eye during the last 4 years. Before that, we have him in, and we missed this patient during the COVID era for 1.5 years. Then we see him again. And when we saw the lastly, this is the finding, he was having a fundus examination, neovascular AMD, and we will do the OCT. It was about 700 in the right, 600 on the left. The visual acuity in the right eye was about 0.05, and the left eye, it was only counting finger 50 centimeter in front of the face. So patient plan for this patient, I discussed with the patient to give him this chance to give these drugs as a new molecules. And usually I start with left eye, the weak eye, so that to avoid if there is any complication or side effect that I don't want to see with these patients. So this is the OCT of the patients when we saw him for the left eye before we do the injection. Then this is the video, but it's not working, unfortunately. So after that 1 week, just we saw the patient, the visual acuity improved in the left eye from counting finger 50 centimeter to 0.5. And the central retinal thickness decreased from 600 to 335. And this is the 1 week OCT. You can see here the difference. This is how it looks like only after 1 week of giving the brolucizumab injection. This is how it is, the video, but sorry, again, the video all not working. A comparison between both of them. This is before the injection and this is after. It's really an incredible of different changes in the central retinal thickness. And I was not anticipating also improvement that much also in the visual acuity, but it was improving very nicely. So in after a 1 month, the vision improved to 0.1, and the OCT decreased to 156, which is a very, very nice achievement in comparison what we are suffering before in different another anti-VEGF before we are using. So this is a follow-up after 3 months after he have the 3 injection in the same eye, and the visual IT is stable 0.01, and the OCT it was 156. So this is also the video, but it's not working. I'm sorry for that. This is another patient, or you can say the same patient, sorry, but in the right eye. So after I use this medication, I become confident. So I start to use it in the other eye, which is the good eye. So the vision, as you remember, in the right eye 0.5, and the OCT was 700. So this 7th of September, when we saw him, the patient, you can see here his, this is the patient before the injection, and this is after 1 week of injection. Okay. This is follow up after 1 month. So vision improved from 0.05 to 0.025, which is the good eye, and the central retinal thickness decreased to 195. This is follow up after 1 month. You can see now the OCT and the fundus pictures and the tomography. It is very nice achievement and improvement in the vision also. Okay, this video also is not working. This is the comparison. You can see now how it was before 1 month, and this is after 1 month injection. This is another case of brolucizumab. It's also a 70-year-old female patient, just hypertensive, had both eye intravitreal injection, ILIA injection. Examination on this was on 20 in November. Counting finger 1.5 meter right eye, and counting finger 50 centimeter in the left eye. Anterior segment examination, sorry. Anterior segment examination, both eye pseudophakic, and intraocular pressure within normal limit. Fundus with AMD both, and the left eye, which I found, it's 400 and 400 OCT showing in the OCT. These are the findings. You can see these findings in before the injection. This is how it looks like, and this is one also, sorry, the fun. This is the video, but not working all of them, unfortunately. Sorry for that. This is a patient examination after 1 week. So improvement. The vision, it's almost stable, counting finger 1 meter, 1.5 meter in the left eye, and there is improvement on the OC, and this is how it changed. You can see this one, OCT finding after just 1 week. And this is the comparison. This is how it looks like 1 week, and this is after 1 week of injection of brolucizumab. This is another patient, maybe the last one I'm going to show here, a 70-year-old female patient also. She's diabetic, hypertensive, high lipid profile. examination was following with me. Sorry, this is a male actually, is not a female. Sorry, but it's a mistake here. So this one, he was see him first visit was in 2016, and this is how he was. He was having a good visual acuity 0.4 and best corrected visual acuity 0.56 over 12. Anterior segment, both eye within very early in the right eye, cataract, and left eye just pseudophakic, and intraocular pressure within normal, fundus macular degeneration and drusen. There was no wet AMD and no edema. Then this patient, we didn't see him more around 5 years. Then he came this visit us, and he's complaining of the left eye visual acuity decrease, and he was having counting finger 1 meter in the left. Anterior segment examination, same finding as before. OCT showed that dry with AMD as before in the right eye, while left it become an with AMD. So I offer the patient also to give the pralucizumab. This is how the patient looks like before the injection, and this is follow up after 2 weeks, and he was very nicely improvement regarding the central retinal thickness, but unfortunately the vision was not changing, it was the same, but we have changed only the OCT changes. In summary, increasing prevalence of MD contribute to vision impairment and blindness. Multiple factors are implicated in conferring the increased risk of development and progression of AMD, including demographic, genetic, eye behavioral, and decrease in quality of life with AMD highlights need for more effective treatment strategies. Also, anti-VEGF therapy has proven efficacy for the treatment of neovascular AMD. However, real-world evidence show suboptimal visual outcomes in a patient, often due to undertreatment. AMD management is a significant burden on a patient and healthcare provider, and poses major challenges for sufficient and sustainable treatment. New therapeutic agent with greater durability that would allow adequate longer-term control of the disease are warranted. And so the take-home message from this: age-related macular degeneration is a debilitating disease, and we should treat it while we still can. Thank you very much.
Thank you so much. Thank you. We'll take all the questions at the end. And thank you for this wonderful knowledge sharing, Doctor. Let's move on to the next speaker. We have Dr. Deepak Kumar Nag, the next session. Over to you, sir.
So can you see the slides?
Yes, we can see.
Okay. So good afternoon. And I should thanks DOS authorities for giving me the chance to speak in this occasion. And I'm going to talk about the pediatric post-traumatic endophthalmitis. As we know that there are many causes of endophthalmitis, but trauma, particularly for the children, is one of the important cause for pediatric endophthalmitis. And the reported estimation showed that it is as low as 3% to as high as nearly 60% of the trauma, pediatric trauma, come up with endophthalmitis. And if we look at the Western countries, although the percentage, overall percentage is less, nearly 17%, but for the Indian subcontinent, and particularly for the developing countries, is quite high. Is nearly 2/3 of the trauma in children come up with endophthalmitis. And of course, we know the consequence of endophthalmitis is very poor, particularly in the children, whether we treat them medically, conservatively, or surgically. Most of the endophthalmitis come up with the tricycle valvi. So one of the important cause for this poor visual outcome is the delay in diagnosis. And there are many causes of delay in diagnosis. Sometimes it happens, this could be seems to be a very simple injury, simple penetrating injury, particularly by, this needle pricking or pencil or compass, and initially there could be no symptom, but later on the child come up with endophthalmitis. And also the another cause is difficult in diagnosis, because sometimes this trauma causes a decreased vision, and also there is pain, and we cannot differentiate whether this this is because of the endophthalmitis or because of the trauma related visual loss. So particularly for the children, when they cannot express their symptoms, it is really difficult to diagnose in early stage. And apart from these two, there are some other also, because trauma related to many organisms, multiple organisms can be embedded in the eye, and also some virulence organism also can be affected the eye. So as we know, everybody, that the endophthalmitis particularly, early diagnosis is very important, and there are some symptoms and also some signs which are very important for the endophthalmitis. But as I mentioned earlier, that for the symptoms, particularly for the children, is not very much reliable and sometimes misleading, and we have to rely on the signs sometimes to diagnose endophthalmitis. So if we look at this picture, we can see it's a penetrating corneal injury, but not seems to be an endophthalmitis. But if we do a B scan, we can see vitreous opacity in the posterior vitreous cavity, which is suggestive of endophthalmitis. There's another case. We can see there is corneal ulcer, and we can guess that there may or may not be endophthalmitis, because once we do this B scan, we can see the vitreous opacity throughout the vitreous cavity, particularly in the posterior vitreous cavity, which is suggestive of endophthalmitis. Another case, which is hypopyon in the anterior chamber, and B scan shows vitreous opacity in the posterior vitreous cavity, suggestive of endophthalmitis. So for the children, signs are more important than symptoms. That is very important message, particularly for the post-traumatic pediatric endophthalmitis cases. So in our observation, we have seen that after trauma, if a child comes with hypopyon or corneal involvement or anterior segment involvement with inflammatory membrane, these people are suggestive of endophthalmitis. But we have to guess which are the eyes can develop endophthalmitis after trauma. So if there is open glove injuries, injury with contaminated objects, if there is retained foreign body, if the primary repair of the injury is delayed, if there is lens capsule disruption, and also in rural and agriculture situations, agriculture injuries, these eyes are more at risk of developing endophthalmitis. So sometimes we need to, this for the adult, we can examine without any sedation or anesthesia, but in children, sometimes we need sedation, deep sedation or anesthesia, otherwise we cannot see the eye very nicely. And also sometimes for foreign body, we need to do X-ray, CT scan or MRI to see whether there is any retained foreign body inside the eye or not. And B scan is very important, as I already showed, and also I will show some more pictures where B scan is very important. So B scan is not only important for the diagnosis of endophthalmitis, but it is also important to see whether the intraocular foreign body inside or not, if there is retinal detachment or not, because sometimes we see that there is endophthalmitis, but there is retinal detachment as well. So for treatment would be different. We cannot give any intravitreal injection for this type of endophthalmitis. We have to go for surgery directly. So B scan will give some more glow, and also it will differentiate with some other diseases which is related to sometimes trauma, but trauma may be misleading. So we can, by B-scan, we can differentiate those diseases, particularly retinoblastoma. You know, patients sometimes come with the history of trauma, but they are actually suffering from retinoblastoma. And there are some disadvantages of B-scan as well. Also, for example, if it is an open globe injury, we cannot do B-scan. So this is a case we can see here. The cornea is involved because of the injury, and B-scan easily shows the vitreous opacity throughout the vitreous cavity. Posterior vitreous cavity is full of exudates. So it's a the another case we can see here. There is a very minor, penetrating corneal injury, but there is a foreign body. So B-scan is very important in this sense. And of course, we can see here there's a corneal ulcer because of this injury, but B-scan shows the exudation in the vitreous cavity, and also there is a retinal detachment. So, I mean, these cases, we have to go for the surgery. We don't have to have any option to go for intravitreal injection. So B-scan is very important for the diagnosis and also for the management purposes, particularly in pediatric traumatic cases. So, and another point I already mentioned, the trauma sometimes can be misleading and come to us with the symptoms of endophthalmitis. For example, this child has a history of trauma 4 months back and was treated with the drugs of endophthalmitis. But once we did the V-scan, it showed that it's a case of retinoblastoma. We can see the calcification in V-scan. So the same situation, history of trauma, but we can see is the case of retinoblastoma. So V-scan, particularly in the traumatic endophthalmitis in the children, it also not only important for the diagnosis, not important for the treatment, but it also differentiate the other cases from endophthalmitis. So one important thing is, once there is retinoblastoma, in case of endophthalmitis, the hypopyon would be the layered hypopyon, and the vitreous cell is usually gray or yellowish gray, and there is no evidence of calcification in the B-scan. So B-scan is very important. Now, if we look at the microbial between the children and adults, most of the studies show the Streptococcus is the main pathogen causing endophthalmitis in children. Sometimes also fungal pathogen also seen, but in case of adult, Staphylococcus is the main most important cause of endophthalmitis. But it is true in developed countries. But in case of developing countries, we have seen that Staphylococcus is the most important pathogen for developing endophthalmitis in case of children, and this may be because of the delay in the primary repair of the wound, because the Staphylococcus usually remains in the conjunctival sac, and once the primary injury repair is delayed, this Staphylococcus may get entry into the eye and cause. So this can happen in developing countries than developed countries. So lots of patients come late in our vitreoretinal department, and that may be one of the cause for the staphylococcal infection. So the same situation happens in our experience also, and we have got nearly 40% of the post-operative post-traumatic endophthalmitis is caused by staphylococcal infection. Now, treatment is also a little bit different, because once for the children come up with endophthalmitis, we have to start antibiotics, definitely oral, intravenous, topical, and sometimes also steroid to reduce the inflammation and also subside the the sympathetic ophthalmitis, oral or systemic. But we cannot start intravitreal, because we need intravitreal for the children. We need access to the sterile environment, and also sometimes we need general anesthesia, which is we don't need for the adult population. Adult population, we can, once we suspect endophthalmitis, we can start intravitreal injection. But for the children, we need facilities of anesthesia or deep sedation, or sterile environment also very important. So this is the situation where we give injection. We can see here that it's better to use trocar to take the sample, vitreous sample for culture and sensitivity, and also the same port we can give intravitreal injection, and at the end of the injection we can also give stitch if we think that it is still leaking. So this is but we have to do it under anesthesia. That is very important. Now, when we'll go for paraspinal in these cases, if intravitreal injection does not work, and if we see that there is no improvement after 24 hours, and if there is retained intraocular foreign body, or if there is retinal detachment, so there is no scope to give intravitreal injection. So in these cases, it's better to go for paraspinal vitrectomy. And also, if we think that this endophthalmitis is due to fungal, maybe vitrectomy is the option of choice. So there are studies. It has been shown that vitrectomy, early vitrectomy with silicone oil tamponade can give us a better visual outcome than the conservative treatment. So this is a patient. We can see here is suffering from endophthalmitis, traumatic endophthalmitis. Trauma is due to the hook of the dress of the mother, and we can see here we have done the surgery, and we can see here this is also very important. This anterior segment, anterior chamber is full of pus and membrane, and sometimes it's really difficult to remove all this membrane because of the fragile iris, and also there could be bleeding during cleaning up this anterior chamber. So sometimes viscoelastic can help. So if we can push viscoelastic several times, and we can see that the anterior chamber is become tight, so that the bleeding is less. And after just cleaning the anterior chamber, we can see the posterior chamber is full of pus. It's really difficult to clean up all this pus. So sometimes we cannot do total vitrectomy. We can just do core vitrectomy and give the intravitreal injection and keep it in this way. And we can see after this procedure, the child's eye becomes so good, the patient can see very nicely. So child can recover very quickly, very nicely than the adult one. This is another case. You can see here that there is papillary membrane, pus, anterior chamber full of cells and flares, so we cannot see the posterior segment very nicely. So we need to wash out the anterior chamber, and then after that, once we clean up this anterior chamber, we can see the sometimes we have to do lancectomy as well, and after the lancectomy and removal of the exudates from the posterior chamber, and then in vitreous cavity, we can see the retina nicely. And then as the retina is fragile, sometimes it happens, this iatrogenic tear is occurs, and after that we can give the silicone oil, and patient has a reasonably good vision after the surgery.
Of the gentle reminder for the time.
This one, a patient, you can see here, this patient has got the penetrating injury because of the heron beak bite, and we can see here the B scan shows full of exudates in the vitreous cavity, and we have done the surgery, and we cannot do actually the total vitrectomy because we cannot see the retina very clearly. You can see here the vitreous cavity is full of pus, and we did vitreous. We did clear the exudates as much as possible. We can see the discs and the retina, but cannot clearly seen. And we have not done posterior vitreous detachment because there are risk of iatrogenic tear, retinal detachment. So we have done in this way, and then we have given the intravitreal injection. And at the end of the surgery, you can see here, after 7 days and after 1 month, the retina looks very good. So sometimes we do need to do total vitrectomy. This is another case. We can see here, this is because of the trauma. The primary repair was done, and then there is endophthalmitis, and we can see here, and the vitreous cavity is full of pus. So we have cleaned up anteriorly, and the posterior vitreous cavity, we cannot see the retina, but very carefully, slow by slow, we have done this, and we can see the retina is nearly atrophied. The blood vessels are almost attenuated. So early vitrectomy is important because you see here the retina, we can see retina, but it's almost atrophied. The vessels are nearly sclerosed. So, I mean, sometimes it's important to do the vitrectomy early so that it gives better result. So this one is my last video. I can see here there is a case of post-traumatic endophthalmitis, and we can see we can see this. There was retinal detachment in this scan before, so we did lensectomy first, and then although there was retinal detachment, we have done vitrectomy. The exudates were so dense that we have done also some iatrogenic retinal cut. Retina has cut here. So, but doesn't matter. We continued vitrectomy, but in this case, we have done total vitrectomy, and at the end we have done laser and given silicone oil tamponade, and at the end we can see the retina is flat and the patient has reasonably good vision after the surgery. So particularly for this post-traumatic endophthalmitis in children, there are still a few questions, and we have to decide during the surgery whether we will go for the complete vitrectomy or we will go for core vitrectomy only, because sometimes this complete vitrectomy we can iatrogenically tear the retina. Sometimes we can complicate it more. So sometimes it happens in case of children, particularly whether if we do the core vitrectomy and give the intravitreal injections, it comes up with good, reasonably good vision, and whether we should go for PVD or not, because PVD is really in this inflamed eye. Sometimes it really can cause damage to the retina. So it is also a matter of decidation during the surgery. And also injection of silicone oil is good most of the time. But if there is no touch in the retina, or there is no retinal tear, if we look at the periphery, maybe we can also keep it under gas. But silicone oil is good, and it can prevent also further retinal detachment. There are some literature that showed that if there is detachment, so in that case, 360-degree silicone band we should give for particularly for this young children or not. So I think if we do the lensectomy, and if we can clear up the exudates nicely and the vitreous completely, we may not need 360-degree silicone band for these young children. So this is some
Doctor, time up.
ideas
I request you please
that most of the patients came to us with penetrating injuries, and also the vitrectomy has given good vision than the other conservative treatments. And also we have looked for those patients came earlier, and we have done the surgery earlier. They have good vision than those came later. So early repair of the primary wound is very important, particularly earlier mentioned that the vitreous is inflamed and endothermitis is developed. Once the anterior chamber wound is repaired lately, because there are many organisms, particularly the staphylococcal organism remains in the conjunctival sac. So it's better to repair the primary injury earlier, and also we have to if we suggest that this is a case of endophthalmitis, particularly in the children, definitely vitrectomy, like the adult early vitrectomy is very important, and it gives better result than the other conservative management. So thank you very much. Thank you.
Thank you so much, Dr. Nag. Thank you. Thank you so much. We have one of the chairperson, Dr. Vaibhav Sethi. Sir, can you please turn on your camera and call up the next speaker?
Yes. Good afternoon. And Dr. Nag, very well described and elaborate presentation. And you made it very simple for us to understand and manage pediatric endophthalmitis, especially traumatic endophthalmitis. My question to you is, in which case, I mean, what is your protocol to get the maximum amount of vitreous exudates, and to make sure that you get some kind of a solution or some kind of organism when you're treating these cases? Do you do vitrectomy under air, take a biopsy under air, or do you have some other tricks down your sleeve?
Hello, hello. Can you hear me?
Yes, doctor, we can hear you.
Hello.
Yes, doctor, we can hear you. Dr. Weber, we are running out of time. So can we call the next speaker? We can take the questions at the end.
Sure.
Hello, can you hear me?
All right. So Dr. Weber, I request you please call the next speaker. All right, the next speaker.
Hello.
Yeah, the
Yes,
next speaker.
hello. Yes, yes. Sorry.
Yeah, here.
Yes, thank you. Thank you. Thank you to the Delhi Ophthalmological Society for inviting me. I'm Dr. Gita Lisa from Jakarta, Indonesia. It's an honor to share here with you. I'm going to talk about Eels disease, diagnosis, management, and long-term results. I have no financial interest. So I think we all know that Eels disease, as first described by Dr. Henry Eels in 1880, is an idiopathic occlusive perivasculitis affecting the peripheral retina, or some would say periphlebitis. It may lead to retinal non-perfusion, neovascularization, and recurrent vitreous hemorrhages. Until the dawn of or the early 20th century, this disease is found in UK, USA, and Canada. but more recently is more predominant in Asian countries, mainly India, Pakistan, and Afghanistan. It's also quite frequently found in my country as well. It's estimated to affect 1% of adult males in India, and usually occurs in young patients between 25 to 40 years old. And a study in India revealed that among 360 patients tested, there 97% had a positive MAN2 tuberculin skin test. The pathophysiology of Eels disease, I think, is still not perfectly clear. It's agreed to be an inflammatory vascular obstructive disease, and multiple proposed etiopathogenesis, among them are Mycobacterium tuberculosis, human leukocyte antigen, retinal autoimmunity, and free radical mediated damages. But the most frequently reported association is with tuberculosis. One hypothesis is the eye shows hypersensitivity to the non-viable or DNA of tuberculosis bacilli. And tuberculosis infection outside the eye results in ocular inflammatory changes due to the molecular mimicry between the retinal antigen and the Mycobacterium tuberculosis antigen. The natural disease of Eels disease can be summarized in this slide. First is the inflammatory stage, where we can find phlebitis or peripheral vasculitis, and then followed by ischemic stage or capillary non-perfusion. And then lastly, the proliferative stage, where we find neovascularization and also vitreous hemorrhage. And the Eels disease is classified based on the new classification by Saxena and Kumar, which divides or classifies Eels disease to stage 1 to 4. So stage 1 is periphlebitis, and stage 2A is capillary non-perfusion, 2B neovascularization elsewhere or of the disc, 3A is fibrovascular proliferation, 3B is vitreous hemorrhage, and stage 4 is 4A is traction or combined rheumatic with neovascularization of the iris, neovascular glaucoma, cataract, and optic atrophy. From the history and general exam, the typical course of Eels disease is initially no symptoms, and then later on the patient may experience floaters, painless loss of vision, photopsia, and this disease is mostly bilateral, although initially appear unilateral, and a detailed examination should be especially for skin, mucosa, joint, respiratory, and also CNS diseases. And the ophthalmological exam, of course, the most important is fundus exam. We could find perivascular sheathing, vitreous cells, peripheral retinal non-perfusion, microaneurysms, intraretinal hemorrhages, ghost vessels, neovascularization of the disc, even the iris, vitreous hemorrhage, and also other signs of ocular inflammation such as KPs, cells and flares in the anterior chamber, and also cystoid macular edema or CME. So three distinctive features are shown here: retinal phlebitis, peripheral non-perfusion, and also retinal neovascularization. The ancillary testings of Eels disease is usually mandated as well. Laboratory investigations are done to screen common etiologies of retinal vasculitis, adjusted based on history and clinical findings. A blood exam should be done, and also tuberculin skin test, chest radiography, and also screening for HIV, syphilis, and urinalysis. And lately, we find the importance of the interferon gamma release assay, or IGRA, to diagnose TB in Eels disease cases. Fluorescein angiography is done to identify peripheral new vessels, the extent of retinal non-perfusion, and also signs of active vasculitis. And sometimes we need to do B-scan ultrasound in cases where we cannot view the fundus to detect PVD, tractional membranes, or retinal detachments. And OCT is done mainly to assess macular edema, usually in later stages of the disease. So the differential diagnosis should be considered as well, because Eels disease is diagnosis of exclusion. Other causes should be ruled out, such as both inflammatory and non-inflammatory should for instance, BRVO, diabetic retinopathy, sarcoidosis, SLE, and other vascular diseases. For the management, patients with inactive retinal vasculitis, we could do watchful waiting for 6 to 1 year interval, and in many cases, we need to do medical therapy consisting of corticosteroids for active perivascular stages, anti-tuberculosis treatment in confirmed patients, and also if not responding to steroids, we could give cyclosporin and also azathioprine. And patients, special precautions for patients with hyperhomocystinemia, we give folate and also vitamin B12. And also sometimes we need to give antioxidant supplementation. And the surgical management usually consists of laser surgery. So laser photocoagulation is the treatment of choice in proliferative stages of Eels disease. And intravitreal anti-VEGF injections are reserved for non-clearing vitreous hemorrhages after conservative treatment. And a surgical management with pars plana vitrectomy is indicated if there's non-clearing vitreous hemorrhage with or without retinal detachment. And multiple vitreous membranes with or without retinal detachment, and also if there is a retinal detachment, either tractional or combined. So regarding the prognosis, blindness in Eels disease is usually caused by retinal detachment and neovascular glaucoma, but visual improvement is usually favorable in cases, especially in cases with fewer episodes and shorter duration of vitreous hemorrhage. And laser photocoagulation before vitrectomy yields better prognosis. So I'd like to share our own local data conducted by Dr. Kadarisman and co-workers, including myself. This is a retrospective study to evaluate the characteristics and treatment outcomes of Eel disease in Jakarta. We gathered medical records from patients diagnosed with Eels between 1919 and 2013 at a national referral hospital. This is my hospital, the Cipto Mangunkusumo Hospital, and a private eye hospital, which is Aini Eye Hospital. And we included patients with a minimum follow-up of 4 weeks. And the results are as follows. So there were 79 eyes from 45 patients with a mean age of 31.47. And 73% of the patients were male, while 75 cases were bilateral. And most of the cases presented to us with vitreous or pre-retinal hemorrhage. So it's almost 50% of the cases. And our treatment for these cases are mainly laser photocoagulation, comprising of almost 70% of cases, followed by vitrectomy. And regarding the visual outcomes of our series, we found that among the 61 eyes that were able to follow up, there was improved visual acuity from 0.5 to 0.65. And especially in the group which presented with vitreous hemorrhage, there was significant visual improvement. The mean follow-up was 8.8 weeks. And overall, there was almost 60% of eyes with improvement, almost 40% of cases with stabilization, and only 2 eyes experienced worsening. And regarding the complications, we found that, mostly there was no serious complications, but there was tractional retinal detachment followed with cataract. And there's also cases with neovascular glaucoma, cystoid macular edema, and also macular scar. Just to illustrate the cases we found, this is male, 23 years old with left eye blur of vision. His initial left eye vision was 6/6 and right eye was 6/20 or 0.3. And we diagnosed this patient with left eye vitreous hemorrhage with a suspected Eels disease. And we did a workup to this patient and treated him with topical steroids. And after 1 month, the vitreous hemorrhage of the left eye cleared up and vision improved to 0.7. But after 2 weeks, massive vitreous hemorrhage, as pictured here, occurred and the vision dropped to hand movement. So we did a left eye pars plana vitrectomy endolaser now, and also bevacizumab intravitreal injection. And this is the fundus appearance of the eye after 2 months of surgery, the left eye improved to 6, vision improved to 6/6, and we can see here laser scars and also fibrosis. But 2 years post-op, the right eye developed floaters, and fundus exam, as pictured here, showed peripheral vasculitis and also intraretinal hemorrhage, although the vision remains 6/6. And we did a angiography to this patient, and we can see here that there's areas of capillary non-perfusion and blockage areas from intraretinal hemorrhage. And here are the leaking new vessels. And I think in the rightmost picture, the neovascular is more pronounced, and the extent of the capillary non-perfusion was quite wide. So we did a right eye laser PRP. And the vision until now, so I followed up this patient until 8 years, the vision remains 6/6 and no visual complaints. And this is the second case, a 53-year-old patient complaining right eye blur of vision since 4 months and left eye floaters. The initial vision of his right eye was hand movement, left eye was 6/6, and we diagnosed him with right eye vitreous hemorrhage, left eye peripheral retinal vasculitis suspected due to Eels disease. We sent him for workup to internal medicine specialist, and we started to this left eye, and also did a right eye pars plana vitrectomy and endolaser. And here are the results. So 1 month after surgery, the right eye, the media was clear. The vision improved to 0.5 or 6/12. And this is the left eye with laser scars. This is done with the pattern laser, not so pronounced as the other one, but the vision remains 6/6. But unfortunately, after 1 month post-op on the right eye, the patient developed CME, as we can see in the OCT of the right eye in November, cystoid macular edema. And then I tried to give him, avoid giving steroids. So I tried giving him anti-VEGF injections. He underwent 3 injections. And this is the most recent OCT. You can see that there's not much, or the CME still persists. And unfortunately, on the left eye as well, initially it was normal, but after 7 months of surgery, the patient complained of slightly blurred vision, and there was CME as well on the left eye. And
sorry,
yes, okay, the patient was, yes,
not visible.
yeah, this is the last one. So the
slides are not visible.
Oh, sorry?
The slides are not moving further.
Oh, okay, so sorry. How do I do it? Can I repeat?
Yes.
My
Please reshare your slide.
Yes, yes, okay. Can you see it now?
Yeah, we on the conclusion slide.
Yeah, okay. So this is the penultimate slide. So unfortunately, on the left eye developed CME, and the patient was also found to be positive for IGRA, and he's still currently receiving anti-TB drugs, rifampicin, also isoniazid, for 9 months. And I might plan to give him systemic steroids and or subtenon steroid injections on both eyes. So in conclusion, Eels disease is a diagnosis of exclusion, but is mainly associated with Mycobacterium tuberculosis, and treatment is tailored to different stages of the disease. Significant visual improvement is found in the majority of eyes with Eels disease following treatment, and periodic follow-up, adequate medical and laser treatment, vitrectomy combined with additional procedure for non-clearing vitreous hemorrhage are the most important elements in dealing with Eels disease, and steroids may be needed in cases with CME. So I'd like to acknowledge my collaborators, Dr. Rumita, Dr. Mario, and Dr. Marsha. And lastly, thank you for the opportunity, Dhanyavad. And I look forward, if the pandemic is over, to visit New Delhi again sometime like I did in 2019 in December for the APOTS meeting. So thank you. Good afternoon.
Thank you, Dr. Geeta Lisa, for a wonderful presentation on Eels disease and your side of the story as well. I'd like to ask you, what is your experience with intravitreal steroids, especially Ozurdex, in case of CME with Eels disease? Do you think
Yes.
it's useful?
Yes, I actually, if the patient is not phakic, I'd like to give him steroids. In if the patient is still phakic, then I might retreat to subtenon or systemic steroids. Maybe I would like to ask the panelists as well. So what should I do, especially in the last case with CME? This is a patient with hypertension, also he's not so young, 50-ish, and still phakic. Would you also recommend giving subtenon injections or other delivery of steroids?
Subtenons or anti-VEGF injection would be my first line of approach, followed by, in
Thank
case
you.
it doesn't get better, maybe an Ozurdex implant, maybe later on in the course of action.
Thank you.
Dr. Nag, Professor Saxena, any comments?
I'm thankful to Dr. Geeta Lisa for including my classification system, which was published
Yes.
in the European Journal in 2004, and I think that classification still remains the mainstay of management, and will obviously help you well in your diagnosis as well as treatment of Eels disease. Thank you.
Thank you, Professor Saxena. We use your classification for our studies as well.
Thank you.
All right, so can I request Chairperson to announce the next speaker, please?
Have you finished all three speakers?
No, Doctor, we have Professor Sandeep Saxena.
Yes. Professor Saxena, sir?
Hello, good afternoon, and I'll just share my slides now. So this has been a very enlightening session, and next I move to diabetic retinopathy. For the past 20 years or so, the macular thickness parameters have remained the mainstay for the diagnosis of severity as well as management of diabetic retinopathy. And now today I like to focus on the external limiting membrane as well as the ellipsoid zone in DME, and I'd also like to discuss the effect of anti-VEGF therapy on these structures. Now, spectral domain optical coherence tomography remains a very useful tool and is extremely helpful to define the dysfunction of retinal photoreceptor layer in diabetic retinopathy. And as we all know that the outer retinal layers on SD-OCT show an inner band which is defined as the external limiting membrane, and the second zone or the band which is nowadays called as the ellipsoid zone. And so now I'll be focusing basically on these two structures. Now, focusing on the external limiting membrane, this layer separates the layers of rods and cones from the overlying outer retinal nuclear layer. And this is basically a linear confluence of junctional complexes between the Muller cells and the photoreceptors. A very noteworthy thing is to have a knowledge that the external limiting membrane comprises of tight junctions within it, and within these tight junctions is a special protein of around 50 kilodalton, which forms a very major component of the tight junctions, which I'll be discussing on later also. Now, this occludin protein has been recognized as an important potential therapeutic target for the control of vascular permeability and also plays and has a significant role in the regulation of the barrier properties. So in the year 2010 or so, the external limiting membrane was proposed as a third blood retinal barrier, which would be worthwhile consideration. Secondly, focusing on the ellipsoid zone. Now, as this figure shows, that in the year 2011, Spade and Curcio in a frog model showed that the second band on the SDOCT corresponded with the ellipsoid zone segment of the photoreceptor and not the ISOS junction, and hence you can say the things were recoined as the ellipsoid zone. And so for the past 10 years or so, I've been focusing my basic translational research on this subject. It's also noteworthy to know that Japanese investigators in a rat model found that after euthanasia, the ELM and the ellipsoid zone disappears or is reduced in intensity. So it might be not a true structure, it might be just a sort of a structure related to the biological activity. That's what they hypothesized. Now, coming to the ellipsoid zone, the integrity of the ellipsoid zone remains a very important predictor of visual acuity in DME. Knowing its importance and subsequently working on it over a few years, we published a very simple classification system for the ELM and EZ disruption, where the grade 0 was no disruption, grade 1 where the ELM disrupted first, and then the ellipsoid zone in those cases was found to be normal, whereas in grade 2, the more severe form, both the ELM and the EZ were disrupted. So noteworthy was that the ELM was disrupting first, and then subsequently the ellipsoid zone disrupted. We also found that as the severity of grade of disruption increased, the visual acuity also decreased. Now, we also try to focus that how else this ellipsoid zone may get disrupted. So we found that we may have a focal disruption or a global form of a disruption. And so we came out subsequently with a second classification system where we found that in grade 0, the whole of the ellipsoid zone was intact. Grade 1 showed a focal or a localized subfoveal kind of a disruption. And grade 2 showed the global or more generalized form of the ellipsoid zone disruption. And working on the ellipsoid zone, we found that the severity of the ellipsoid zone disruption increased with the severity of retinopathy, as well as that was also increased, that was also associated with an increase in the logMAR visual acuity. We also found that an increase in the macular thickness parameters was also associated with an increase in the ellipsoid zone disruption. So as the VEGF levels were increasing, the macular thickness was also increasing, and the grades of ellipsoid zone disruption were also increasing. And so we were able to discover the mechanism of the ellipsoid zone disruption. We measured the VEGF levels in the patients of diabetic retinopathy, and we found that as the VEGF levels increased, there was an associated increase in the EZ disruption. Now, the VEGF and the occludin protein, which I had discussed earlier, have a very important interplay. The VEGF alters the ELM tight junctions and promotes also the vascular permeability in the retinal vasculature. The VEGF induces the phosphorylation of occludin protein, and hence leads to a breakdown of the barrier effect of the ELM. And so all of this, my talk may be summarized that an increase in the VEGF leads to a phosphorylation of the occludence on the retinal vasculature level, there is an increased permeability of the vasculature, which causes the DME in the form of increased macular thickness parameters, whereas the phosphorylation of these occludens lead to an ELM disruption and subsequently the EZ disruption. So based on this work of over a decade or so, subsequently we were able to discover the mechanism that how the ELM and EZ restoration was happening after anti-VEGF therapy. And our work was focused on about 150 injections given sequentially in 3 doses. And we found that the effect of anti-VEGF therapy on the tight junctions of the ELM might have led to the restoration of the barrier effect of the ELM, and hence as the external limiting membrane restored, it was followed by a sequential restoration of the ellipsoid zone in about 80 to 90% of these cases. And this just one case example basically defines that. On the slide on the left, pre-treatment slide, you can see that both the ELM as the ellipsoid zone are disrupted, whereas the slide on the right shows, if you see carefully, that after the 3rd dose of the anti-VEGF therapy, the ELM has been restored and the ellipsoid zone is in the process of being restored. So this clinically corroborated with our past work of 2013, and now we have a basic mechanism that after anti-VEGF therapy, although the macular thickness is going down, how the photoreceptor layers just restores itself, we have been able to define it well, and that was published last year. And lastly, coming to my last slide, it has been shown that the photoreceptor restoration contributes to an improvement in the visual acuity after intravitreal ranibizumab injections. However, this is not dependent on the resolution of the macular thickening. So it's quite a possibility that the ellipsoid zone and the ELM may restore back, whereas the macular thickness may still be in the process of being decreased. So this sort of body of my work over the past 10 years has especially focused on the ELM and the ellipsoid zone, that how the VEGF is contributing to its disruption, and how the anti-VEGF therapy helps in the restoration of the ellipsoid zone, just because the barrier effect of the ELM is restored. Thank you very much.
Thank you very much, Professor Sandeep Saxena, sir, for a lovely talk and explaining us how the ELM and the ellipsoid zone is so important in gaining vision and the role of anti-VEGF therapy at the molecular level. I'd like to ask you a question. What about the intravitreal use of steroids? Have you studied that, and what do you think about?
Well, I have not studied on the intravitreal steroids yet, but definitely now as the things are developing, inflammation plays a very important role. So what my clinical acumen suggests, that in case anti-VEGFs are not responding well, or the patient is not responding, then we should add steroids also with the treatment, and that may have a synergistic kind of effect. Thank you.
Dr. Vaibhav, I think next talk is of Dr. Natarajan, sir.
I'll have the pleasure to invite Professor S. Natarajan, sir, for the next talk, and he'll be talking about the fantastic 3D surgery he does.
Thank you, Subhash, and thank you.
Good afternoon, sir.
Good afternoon. Thank you very much. So I just went to, today is my father's death anniversary. So I went and did, what do you call that? The served free food to people in outside KM hospital. I'll share my screen. Presentation. 1 second. It's no problem. Yeah, open it. So my experience with the RTO, sorry for the initial beginning. I don't have any financial interest. This is the RTO, the 3D one. So I'll directly go to the original one which I downloaded, did not download. I want to show you the video. The main thing is that I totally use for the last more than a year using the RTO. The reason is you have whatever you see, this is not there. So the main reason is I do all my 3D surgery because the diabetes India is actually having the highest. So you land up in traction retinal detachment in untreated diabetic eyes where they don't undergo pan-retinal photocoagulation or treatment. They land up in non-clearing vitreous hemorrhage or even combined traction retinal detachment or a taut posterior highlight. And also you have a rubeosis iridis associated with the vitreous hemorrhage. And these are the causes for diabetic blindness, the diabetic macular edema, traction retinal detachment, and neovascular glaucoma. So we have the entire scope of treatment, and I am actually sticking to my topic of performing 3D vitreous surgery, where this is a 48-year-old male with a sudden diminution of vision in both eyes, and he comes with a, so unfortunately you cannot transmit the 3D, and I'm talking to the organs, they are able to do that. So this patient, you did a report 25 gauge or a 23 gauge pars plana vitrectomy. You make the remove the anteropost traction as well as clear the vitreous hemorrhage, and make sure you have a PVD and And if the PVD is not there, induce PVD, and then make sure you remove all the anteroposterior traction. And then now you see the fibrovascular proliferation after you clear the vitreous hemorrhage. You can see the vitreous is still attached to the posterior vitreous, and then the fibrous membrane also is attached. Now I'm doing a diathermy to the vascular part of the fibrovascular membrane, and that's why if the patient has already undergone a good laser photocoagulation and then developed fibrovascular proliferation, many times the surgery will be easier. But here you see, in spite of the diathermy, there is some ooze happening, and then you make sure that you don't go near the optic disc. The idea, because diabetic vitrectomy produces even optic disc pallor, and we're all interested in making the patient see. And then intraocular pressure also, I keep it low. I operate in 20 millimeter in the intraocular pressure. And here you also have less light because of the 3D. It can pick up the details. When you see, you can see the clearing the surface of the membrane, and then the retina, and then you make sure that the entire retina is clear, and you can use the retinal brush to clear the pre-retinal hemorrhage over the surface of the retina. And here I'm actually sucking the blood and then pushing it back. It's like sucking and spitting. The idea is to stir the vitreous hemorrhage, and here I'm doing a pan-retinal photocoagulation where the patient did not undergo any laser prior to this. So this is what I want to convey. I think even though we can do advanced vitreous surgery, I think every patient and every ophthalmologist should be aware that if you diagnose and screen the patient early, and then you treat them with laser, many patients may not land up in doing high-tech surgery like this. So here you complete 360-degree pan-retinal photocoagulation except the optic disc and macula, and I finally leave the eye with the non-expansile SF6 10% mixture just to avoid recurrent hemorrhage happening. And before this era of fine gauge and intravitreal, you are landing up with recurrent hemorrhages. Here you see a pre-op traction retinal detachment, and you'll be seeing that I'm doing a 23 gauge again, removing the vitreous hemorrhage as well as the anteroposterior traction, and then identify the fibrovascular proliferation, and you can see there are pre-retinal hemorrhages and fibrovascular proliferation. Here I use the proportional mode. After I clear, I'll show you. Here you see the fibrovascular membrane is actually removed, and I'm using the cutter itself and removing the some amount of laser has been done in the past. You can see that I'm using the cutter, and I go to the convex surface of the membrane. So the advantage of the 3D is whatever you're seeing, the assistant, the nurse, and anybody can see, and that's where you can also sit relaxed. And again, I don't have any financial interest, and I want to say that the comfort of surgery, finally the benefit of surgery goes to the quality of vision to the patient, because you'll be able to recognize a membrane and the retina, and almost like you see a difference between the two papers. And here I'm using the proportional mode by passing the fluid between the membrane and the retina. It may take time, but I think this is what I do. And then after cleavage, I go to the convex surface of the membrane and then keep removing. So the idea is with micro-incision vitreous surgery, without forceps and scissors, I can use a proportional mode, remove the entire membrane. It may take some more time, but I think the whole thing is to avoid iatrogenic retinal breaks. And this is possible. You can see the blood was pushed out, and this is the suck and throw, or a suck and spit, and that's the same thing can be done. And here you see, in spite of the diathermy and everything, you see pre-retinal hemorrhage happening. I use the retinal brush and clear the surface of the retina, and then do a pan-retinal photocoagulation and leave the eye with the non-expansile gas. And then this is the post-operative vision. You see the optic disc pale, but the vision is 6/9, post-vitrectomy, no sign of any membrane, and good laser photocoagulation. This is a third patient with a combined cataract when I have Dr. Kavita Rao as our director of cataract and cornea services. She does the cataract. They do the phaco with the foldable intraocular lens. And I always tell them, the anterior segment surgeon, to complete the cataract surgery, that means do a phaco emulsification with an intraocular implant. In case they want to put a suture, they can put one suture, but otherwise you can leave it sutureless and then do the surgery. And then here the idea is to we can do the combined surgery. And here you see she's doing the cleanup, and then she'll introduce the lens, and then I proceed with the 3-port pars plana vitrectomy. And here you see it's a combined traction retinal detachment. The patient had almost a total brown cataract with a vitreous hemorrhage with a traction retinal detachment, which was diagnosed in the ultrasound. And here you see a rhegmatogenous break and a fibrous tissue which is producing the traction. It's a combined traction and rhegmatogenous retinal detachment. I'm delineating the fibrous tissue and the retinal break. The idea of the diathermy around the surface, around the break, is to identify the break after fluid air exchange so that you can do a thorough photocoagulation. You're also removing the fibrous tissue between the optic disc and the traction and the fibrovascular proliferation, which is connecting to the retinal break, so that all traction is totally removed. And here I'm still diathermizing to avoid fresh pre-retinal hemorrhages. Because once upon a time, recurrent vitreous hemorrhage was a big bear, and because of that, posterior subhyaloid fibrous proliferation used to happen, and that was producing hemorrhages, and that also produces neovascular glaucoma. Now all that can be avoided, and still I want to reiterate, even though I'm an advanced vitreoretinal surgeon, I will prefer patient to be screened early, treat early with laser, intravitreal injection, so that you don't land up into complicated situations like this. But in case you land up, don't give up. You may be a comprehensive ophthalmologist, but you can diagnose and refer to a colleague who are doing advanced vitreoretinal surgery, and vitreoretinal surgeons are available all over our country. And I'm sure that people now we have several of them in the panel here. See, I'm here diathermizing and make sure that there's no traction between the optic disc region and the nasal side of the optic disc. And then I do endodrainage. I use a perfluorocarbon liquid between optic disc macula and the break. The idea is to flatten the retina so that no epiretinal membrane produces traction. And I make sure that now I use the forceps. The perfluorocarbon liquid acts as a third hand, and then when you lift the membrane, the perfluorocarbon pushes the retina, so that the third hand, it is like pushing with one hand and removing it with the other hand, and you see the membrane is totally removed and the traction is relieved. So finally the whole idea is to release the anteroposterior traction, pull on the retina, and then finally reattach the retina using endodrainage and fluid air exchange. Here I'm using the retinal brush and doing endodrainage. Still the perfluorocarbon liquid is there, and once the endodrainage is done, the PFCL actually presses the retina, and so that the subretinal fluid is not there near the optic disc region, and make sure it's totally dry, and finally remove the PFCL, the last bubble also, and make sure the entire vitreous cavity is filled with air, and then you do the endolaser photocoagulation around the break. The idea is to clean the retina, make the surface of the retina flat, and then there's no visible traction, and there is no membrane seen. If required, you can use a methylene blue, brilliant blue to stain the epiretinal membrane, and then finally complete it with the endolaser photocoagulation. And if in case there is no other traction, you can leave the eye with gas. And in some eye, if the patient cannot come for follow-up, I think then better use oil so that the patient can come back maybe 2-3 months later and then think about removal of oil, and then complete the panretinal photocoagulation so that the anoxic retina is treated. Thereby, there's no need for future antivascular endothelial growth factor treatment. And nowadays, I also, after removing the traction, removing the vitreous hemorrhage, I also inject antivascular endothelial growth factor at the end of the surgery to avoid recurrent proliferation happening. And here you see some part of the fluid is removed in the last part, so the entire eye is totally with the air or a 10% SF6 gas in the eye. And you see the eye, you can see the one suture, the intraocular lens implant, the cataract, and so you can do a combined cataract vitrectomy and endolaser. So this is a twin light. I think Dr. Subhash, I have a few 1 or 2 minutes.
Yes, sir, you have.
Yes, sir.
Please carry on.
Okay, sure. So this is a twin light which yesterday I showed in the retinosum program with Brazil and the US. So here it's a stiletto introduced by Dr. Klaus Eckhart. And I use this. The idea is to avoid a shadow, and you can see the twin light will be introduced, and I can do a bimanual, which is surgery. And I'm an ambidextrous surgeon. I think I recommend that a young vitreoretinal surgeon should become a versatile surgeon, where you can, whatever you can do with the right hand, and you should be able to do with the left hand, and vice versa. The idea is that use both the hands usefully, and also, so you can see here, I catch the, you can see the illumination, even though there is some shadow, but still you can see the things beautifully well. And I'm now catching the membrane, and then cutting with the curved scissors. It's exactly like a curved one-off scissors, designed again by Dr. Relja Jovanovic, my second mentor in Antwerp, who's retired 20 years back. But his contribution is immense, and he was called the father of modern vitreoretinal surgery. So here you can remove the membranes like this and thoroughly, and then finally intermittently use the cutter and then remove membranes. And this is here the second surgery. You can do a similar surgery, and again I'm catching the membrane, removing the. So any complex combined traction retinal detachment or a diabetic traction retinal detachment can be done. And you can see here, again I'm removing the fibrous tissue. I practice removing the fibrous tissue en masse. The idea is one day we can do some histochemistry and histopathology, and then you can use it for any academic studies also. So here you see, I'm removing the membrane in total and also cutting it with a cutter, so that finally the entire traction is removed. Then you do a fluid air exchange and oil, air oil exchange. So the favorable preoperative prognosis is a short duration of macular detachment, limited extent of detachment, presence of preoperative pan-retinal photography, which is a problem. I hope we can make sure we can detect every diabetic and have examined the retina, absence of vitreous hemorrhage, visual acuity 5/200 or better, absence of rubeosis. But again, I want to tell the general ophthalmologist, if there is the rubeosis also, I inject antivascular growth factor into the AC, the rubeosis regresses, and then if possible, do a pan-retinal photocoagulation or vitrectomy pan-retinal photocoagulation, so that you can avoid a painful blind eye. If there is some vision, at least there can be a use of unfavorable, again, as a combined retinal detachment. And then 3D is a revolutionary technology to change the way a surgeon performs VR surgery, benefits both the surgeon, patient, the students, and the OT team, and can be widely accepted platform in future. And the traditional vitreoretinal surgery posture is difficult to maintain, leads to musculoskeletal pain, discomfort in the long run. But I suggest to do dance and exercise, which is what I do, apart from having a 3D. 3D is expensive, but doing exercise and making the abdominal muscles and the back muscles strong is best. Uses direct view of endo-illumination, sometimes with the static filters. Prolonged exposure of patient's retina to microscopic illumination or endo-illumination is avoided. And it's a 3D high definition camera, a computer with a process, and 3D glass to view and this is the setup. And then it also improves the improved ergonomics, and that's how I sit. You can see I always sit erect, and then the shoulder weight is to the elbow, and elbow weight is to the arms, and that is there in the armrest, as you see here, and it's I call it a Maharaja chair. And then digitally enhanced visualization, where you can use the digitally applied filter, and you have real-time response, even though there is some delay, about a few seconds, but I think a good adaptability, it's advanced teaching tool. That's why I love teaching, and that's why whatever I know, I want to teach the world, so that the whole world can benefit what I know. And that's why I'm in a webinar all over the world, and any part of the world, I'm continuously on various teaching mode. Sometimes I wonder why should I do that, but I enjoy doing it, and that gives me endorphin. So finally, even though I'm an advanced VR surgeon, as an immediate past president of All India, I have made this program, Screening through Teleophthalmology for Prevention of Diabetic Blindness. I would like to work with Dr. Subhash Dadia, with the government of Delhi, and produce this Jyot along with the Delhi government. And our former president mentions this: diabetes invariably affects both eyes, test your eye zone. This is my late father, whose death anniversary is yesterday, and today I did the free distribution of meal, and that's my late grandfather, Dr. Rajapalli, who was also an ophthalmologist. All three of us put together, we are doing 150 years of service to the nation. It's like called the man hours to the nation. So I follow Swami Vivekananda. They alone live who live for others, and rest are equivalent to dead people. So in case if any of you are not doing something for others other than yourself, I think you are equal to a dead person. And I'm happy to say that because I want you to change forever. And which is a 100 years old museum, the first museum in the world. And thanks to Dr. Namrata, we have a ophthalmic museum in our headquarters. I request Dr. Namrata and Dr. Subhash Daidya to invite all our DOS members to the headquarters to see the museum. And thanks to my fellow Dr. Aishwarya Iyer and my executive Shubha for making this possible. Thank you very much.
Thank you very much, Dr. Natarajan, for a wonderful talk and for making us and everybody very aware of what the essential part of diabetes is and how it should be the comprehensive ophthalmologist can tackle it and even prevent such kind of a bad traumatic advanced diabetic retinopathy to happen.
Dr. Deepak, how is Chittagong?
Dhaka, I'm fine. How are you?
Okay. Dr. Geeta Lisa is there from Indonesia. How are
Hi,
you?
Prof. Natarajan. Very nice to meet you and all of you.
Thank you. How are you, Sandeep? From Sandeep Saxena? So I want to say.
Left. I think he is.
Sir, we are all doing fine.
Yeah.
Oh, yes, he's there. So, Subhash, I want to say thanks to Dr. Sandeep Saxena and his student who's a consultant with me, Dr. Asta Jain. We have made a beautiful book, Principles and Practice of Vitreous Retina Surgery, which is already ready and we'll be releasing in the All India. Thanks to
Sir, I mean, we all are fine until now because the Bangladesh situation is very grave day by day. We are now.
But India is crossing that, no? India is very bad.
Yes, so we have to keep ourselves in safe always, and we have to pray for each other to remain safe.
Yeah.
So he is there to protect us, India and Bangladesh and Indonesia. And last year, February 7th and 8th, Geeta Lisa promised me and called me to Indonesia, and I didn't understand what is COVID. And we saw they did the temperature check in Jakarta, and I was also in China. Thank God I'm safe.
Yes.
Terima kasih.
Yeah.
But I'm missing my travel.
Sir, have you completed your second dose?
No. I did my antibody. I have 70. My physician said take it on the 10th week. So it's great. And I take all precaution, wearing mask, glove, PPE while surgery, as well as when I go to distribute food. That's the roti bank, which you can see on the back. We daily serve 10,000 people free lunch all over Mumbai. So that will protect all of us.
Yes.
And thank Subhash for he's doing a great work for both Delhi Ophthalmic Society, and now for All India Ophthalmic Society.
Now we are really grateful to Dr. Subhash because he has actually arranged such a wonderful event in this Corona situation, and we are really grateful to him and given us the opportunity to talk and meet together in this grave situation. Thank you, Dr. Subhash. Thank you very much from Bangladesh.
Subhash is also working for what do you call our All India Ophthalmic Constitution reformation. So we want to reform, and I take this opportunity to thank Subhash. I won't say anything more.
Thank you, sir. Thank you very much, sir.
From Bangladesh, we all thanks Dr. Subhash.
Yes.
Thank you, sir. Thank you, Dr. Deepak. Thank you, Dr. Geetanja, and
Thank you, Dr. Subhash.
Thank you, Dr. Natarajan, sir, and thank you, Vaibhav, for moderating the session very well.
Vaibhav is doing a good international program regularly. All the best, Vaibhav. And thanks to your dad and mom for producing such a wonderful veterinary surgeon. And I know Geeta's mother also. She is also a VR surgeon.
Yes.
Thank you very much, sir.
So thank you very much, and we will meet at 6:30 in the next session.
Yeah,
Thank you so much.
There in the international session. Yes.
Thank you
John
so much.
Prakash.
Thank you. That was absolutely
Subhash.
wonderful session on retina. We'll meet at